Thank you, Mr. Chairman. I would like to welcome you once again and thank you for staying till now. I'm going to talk about hyperthyroidism and subclinical hyperthyroidism, so it's two in one. So you have to be patient with me, and I apologize for being fast. This is my disclosure, and this is the objective of my talk. I hope I will be able to present the two cases that we have in this discussion. And before I start, I know everyone know about this, but just only to remind you with the physiology, you know that thyroid hormone is secreted in inactive form, T4, and that is regulated by the TSH secretion from the pituitary, and which is influenced by the TRH production from the hypothalamus. And the homeostasis is maintained by the negative feedback loop to both the pituitary and the hypothalamus. And the inactive T4 will be deiodinated in the liver to the active form T3 that acts on the peripheral tissue. Just only to draw your attention that there are several reports on the relationship between TSH level and aging, with some progressive increase and decrease in relation to age, and this postulated to the hypothalamic pituitary thyroid axis with aging. And as you can see here in this slide, the curve for TSH is narrow in a younger age, and as the age goes higher, this curve gets wider and even further wider at a higher age with a higher level of TSH as probable normal range for elderly population. Similarly, it has been found that the TSH may go even down with the extreme age, like age above 100, and the FT3 also showed some decline with age. However, the FT4 remained constant with no changes with aging. Hyperthyroidism is defined as an excess synthesis or release for causes which could be either endogenous or exogenous causes. However, the definition of subclinical hyperthyroidism, which is a biochemical abnormalities with a potential hidden impact on survival and quality of life that may hide and may really have higher prevalence or progression to overt hyperthyroidism with some cardiac effect and skeletal effect that we are going to discuss. And it is defined as persistent subnormal TSH documented with a repeated TSH in 3 to 6 months with a normal T4 and T3 with minimal or no symptoms that recovers spontaneously with or without treatment. So because of the absence of significant symptoms, most of cases of subclinical hyperthyroidism are diagnosed during routine screening for other conditions. The prevalence can be up to 1.6, however, the overt hyperthyroidism can be up to 0.6, and subclinical hyperthyroidism is more common than overt hyperthyroidism, and actually the prevalence really depends on the ethnicity, the gender, and the age, and the dietary iodine, as well as the lower cutoff point for TSH, so the prevalence can be as high as 16%. And it is more common in women, smokers, older individuals, and as we are going to see, exogenous causes are more common than endogenous causes. Whenever you look at a patient with abnormal TSH, you should always keep in mind other causes for altered TSH level, and this is included in this list. And on top of the list here, you can see the infection and sepsis, especially for hospitalized patients, critically ill patients, other causes like anxiety, depression, other diseases like anemia or chronic fatigue syndrome or atrial fibrillation due to other causes, or pheochromocytoma that may give similar presentation to hyperthyroidism. Should always keep it in your mind. This is a busy slide, but just only briefly to show you the many causes of hyperthyroidism. On top of the list is the Graves' disease, Hashimoto's, toxic adenoma, toxic multinodular goiter. You can have TSH-mediated hyperthyroidism, human chorionic gonadotrophin and hyperthyroidism, thyroiditis, whether subacute, painless, drug-induced, or radiation thyroiditis, exogenous due to either factitious or excess replacement of thyroid hormone, and ectopic hyperthyroidism, really like stroma ovary. And it is very important to establish the cause of hyperthyroidism before starting treatment, because the decision for treatment and the prognosis and the recurrence and relapse rate will depend on the underlying cause. As you can see here, Graves' disease is the most common cause of hyperthyroidism, account for 60% of the cases of hyperthyroidism, followed by the toxic multinodular goiter, which is more common in elderly individuals, and subacute thyroiditis account for 20% of the cases. Most of the time is viral and usually is painful and tender. You can have toxic adenoma in up to 5% of the cases, and it is common in younger individuals in iodine deficient regions. And postpartum thyroiditis is another entity that can range between 1 to 17%, and most of the cases they go to euthyroid state within 6 to 12 months, and they may present either with transient hyperthyroidism that goes to normal in 6 months, or transient hypothyroidism that normalizes after 6 months, or they may have biphasic with the phase of hyperthyroidism followed by a phase of hypothyroidism and then normalization, or they may have persistent hypothyroidism after 6 months, and some of them they may have persistent hyperthyroidism. And those cases, rather, they are Graves' disease rather than postpartum thyroiditis. So other causes include the factitious or iatrogenic hyperthyroidism due to overtreatment with thyroxine, and the rare cause of TSH secreting pituitary tumor as a secondary cause of hyperthyroidism. Hashimoto's thyroiditis or hashitoxicosis, again, this is another cause that may have an overlap and misdiagnosis as Graves' disease. Usually they resolve within less than 6 months, and some of them they will go into euthyroid, some of them they will go into hypothyroid state, some of them they will keep fluctuating, and this is very interesting. They can fluctuate between hypo and hyper, and they may go after hypo even to hyper again, and I have seen few cases like this in my clinic. Drug-induced, like amiodarone thyroid-induced hyperthyroidism. As we know, amiodarone is a drug used to treat arrhythmias. It's high in iodine, and it inhibits the peripheral deionation. And in up to 25% of the patient may present with hypothyroidism, and another 20% may present with thyrotoxicosis. And patients with amiodarone-induced thyrotoxicosis are at high risk of adverse cardiac events. And amiodarone should be used with caution, especially in patients with hyperthyroidism and impaired LV function. Really is very important to recognize those people. Symptoms of hyperthyroidism, we are all aware about the symptoms of hyperthyroidism. Patients may have additional signs that may help to differentiate Graves' disease from other diseases like the goiter, the exophthalmos, the dermopathy, the acrobachiae clubbing, and osteoarthropathy. They may have exophthalmos with lid lag, lid retraction, and they may, and you know how to evaluate for exophthalmos and using the exophthalmometer to assess the degree of exophthalmos in response to treatment. And some of them they may have even ophthalmoplegia, and in severe cases they may have exposure keratitis and ulceration of the cornea. Another important entity is what we call epathic or non-activated thyrotoxicosis, and this is a very dangerous degree of hyperthyroidism that takes place in people with pre-existing chronic condition and illnesses, more common in elderly population, and it carries a very high mortality if not recognized. And they usually may present with cardiac manifestations or inability or abnormal behavior, and if not recognized, they may go into coma and even die if not treated appropriately. About subclinical hyperthyroidism, most of them may have minimal signs and symptoms of hyperthyroidism. However, half of them might be asymptomatic, and when you have such cases asymptomatic with abnormal TSH, should always consider other possible causes other than thyroid diseases. So just only to summarize how, if you have a suspected case of subclinical hyperthyroidism, the most important first thing is you have to rule out artifact, and this is, I think, common in our practice. So you rule that by repeating the test immediately, and if it is still low, then you have to demonstrate that this is a persistent subclinical or abnormal TSH by repeating the test in 3 to 6 months. If it is still low, then you should look for the causes, and causes as either endogenous causes, and the list of endogenous causes similar to what we have discussed in hyperthyroidism, or exogenous causes, and this is more common as a cause of subclinical hyperthyroidism. And as we know that 1 out of 5 patients treated with thyroid hormone showed suppression of TSH, and factitious and excess dose of thyroid hormone for easy and weight loss has been still seen in our clinical practice. And another thing is during the recovery phase of hyperthyroidism, whether with treatment or recovery phase of thyroiditis, you may get transient reduction of TSH with normal FT4 and FT3, so you have to keep this in mind. Again, non-thyroidal illness, always keep in mind whenever you look at any of those kind of thyroid function tests. What are the risks associated with hyperthyroidism and subclinical hyperthyroidism? It can be associated with cardiac manifestation, musculoskeletal, and it can be associated with cognitive and mortality effect, and it is more likely to show those effects in elderly population and with more severe degree of TSH suppression, as we are going to see. So thyroid disorder and the heart, when the thyroid speaks, the heart listens. So we know the strong relation between the thyroid gland and the heart, and whenever you get a disorder of one, it will be manifested in the other organ. And what happens in hyperthyroidism is magnification of the or exaggeration of the normal physiological condition. We have short-term and long-term effect, and it is important to note that this increase in the or magnification of the cardiac output and the cardiac manifestation may be up to 300% of normal. And what is also important to note is that this is reversible, because the thyroid hormone does not lead to cardiac fibrosis. So if you recognize and treat early, it may help to return the heart to normal. Sinus tachycardia is one of the common manifestations of hyperthyroidism. Atrial fibrillation, in an observation study, hyperthyroidism is presented in 10% of patients presenting with new onset atrial fibrillation. And it's important also to note that treating hyperthyroidism will normalize the atrial fibrillation. Risk factor for hyperthyroidism and atrial fibrillation is male sex, increasing age, and the presence of underlying cardiovascular diseases. Overt heart failure in thyrotoxicosis may occur in up to 19% of the patients, and mortality rate is high in those people, up to 30%. And the people at risk of heart failure with hyperthyroidism, again, I will keep repeating this, age is an important factor, the severity of the disease, and the presence of underlying cardiac condition. And overt hyperthyroidism in elderly population with pre-existing heart disease or hypertension is susceptible to develop heart failure and increased cardiac death. Right heart failure, there have been some reports of an isolated right heart failure with hyperthyroidism due to increased blood volume and venous return, and also some cases, rarely, of pericardial effusion. However, we know pericardial effusion is more common in hypothyroidism, but we can see as well in hyperthyroidism. Cardiomyopathy, some authors believe that there is a specific thyrotoxic cardiomyopathy which is reversible with treatment, and it's important to report such cases, because if you give them the proper treatment, this cardiomyopathy may be normalized. Autoimmune hyperthyroidism has frequently been also linked to autoimmune cardiovascular involvement, pulmonary arterial hypertension, myxomatous cardiac valve disease, and autoimmune cardiomyopathy, and it has been reported in people with Graves' disease. Thromboembolization, we know that thyrotoxic atrial fibrillation increases the risk both for stroke and for pulmonary embolism, even if the cardiovascular system is normal. Even if there is no cardiovascular disease or valvular disease, they are at higher risk of embolization, and this is due to the hypercoagulable state and the procoagulant factor. So such patients should be, also recommendation is to anticoagulate them if they have atrial fibrillation. Hyperthyroidism may aggravate underlying coronary artery disease, and also it has been noted that people without coronary artery disease, they may present with classical signs and symptoms and ECG changes like people with ischemic heart disease without evidence of coronary artery disease, and this is due to the coronary spasm and prothrombotic state. What happens in subclinical hyperthyroidism? Again, heart failure could be a manifestation, but the lower the TSH is, the higher the manifestation with heart failure. Similarly, atrial fibrillation may be the manifestation, and it can be up to 13%, similar to people with overt hyperthyroidism. And in this slide, I show you the relation between the risk of atrial fibrillation and age. The higher the age is, the higher the relative risk for atrial fibrillation. Effect on bone. Overt hyperthyroidism is very well known and recognized risk factor for osteoporosis and increased risk for fracture. In subclinical hyperthyroidism, this issue is controversial. However, there are some evidence showing that there is increased risk, especially with lower TSH. And the severity will depend on the severity and duration of TSH suppression. Also, elderly men, they are frail and they may be predisposed also to osteoporosis. What about cognitive function? It has been also a strong correlation between overt hyperthyroidism and cognitive impairment, and they can present with different manifestations like mood changes and impaired concentration and altered behavior. However, again, this link is controversial in people with subclinical hyperthyroidism. However, again, more studies have shown that there is some link, and still we need to know whether the treatment may change this association or not. Mortality. It is known that hyperthyroidism increases the mortality independent of the pre-existing comorbidity. However, in subclinical hyperthyroidism, this risk again is affected by the age and the severity of TSH suppression and the presence of underlying cardiac disease. And in this slide, show you the risk of death that increases over time over time in relation to age. The higher the age, the higher the risk, and this risk is higher in male as compared to female patients. Now we go to the assessment and the thyroid function test. Should we screen all patients? Screening is not recommended in healthy people. However, if you have a symptomatic patient or an elderly patient who present with vague symptoms, then you should do it. And also people at high risk like type 1, type 2 diabetes, and people on lithium, and people who received irradiation, or people who present with cardiac manifestation without previous cardiac abnormalities. What about in sick conditions and in ICU? It is not recommended to do thyroid function test because we know TSH go into different changes during illnesses, and the magnitude of changes will depend on the severity of the illness. They can present biochemically like primary or secondary hypothyroidism or hyperthyroidism or subclinical. So it is very important not to order it until you strongly suspect the disease. And if you don't order TSH alone, you should also order FT4. And you should go for labs that can detect a low TSH of up to 0.01. And if the level is really very low, undetectable, then probably this is hyperthyroidism. But if it is low but detectable, most of those people will revert to normal. Thyroglobulin, it has more role in the differential diagnosis of thyrotoxicosis. It's a tumor marker for cancers. However, it has been shown that it may differentiate certain cases between thyrotoxicosis and thyroiditis, decreased in thyrotoxicosis and increased in thyroiditis. What about thyroid antibodies? We know that thyroid antibodies, thyroglobulin, TPO, and TSH receptor antibody, they are highly positive in people with Graves' disease and Hashimoto's thyroiditis, but we have to keep in mind that normal people can have positive antibodies. Similarly, people with other autoimmune diseases other than the thyroid, and in elderly population, all they can have positive antibodies. So it is not recommended routinely to screen with antibodies. However, these antibodies may help to predict people who will go into full overt hyperthyroidism or hypothyroidism if they have subclinical hypothyroidism or hyperthyroidism, and also people on medication. So, not recommended for screening. You screen people if you don't have a clear picture of Graves' disease, people at risk, like people on medication, and also to differentiate postpartum thyroiditis from Graves' disease, as we mentioned, that may be sometimes confusing. So what about thyroid ultrasound? I'll just briefly go to this patient. This is a 71 years old diabetic. He presented with classical symptoms of hyperthyroidism. Clinically, he has diffuse nodular goiter, and he has exophthalmos, moderate exophthalmos, and biochemically, he is toxic. So raise your hand. How many of you will do ultrasound for this patient? How many of you will treat this patient as Graves' disease without ultrasound? So only 1, 2, okay. So actually, according to the ACE and Endocrine Society, you should not do routinely ultrasound thyroid for patients with thyroid abnormality, and actually ultrasound does not generally contribute to the differential diagnosis of thyrotoxicosis. However, if you have limitation of resources, increased vascularity on ultrasound of the thyroid gland may sometimes help to differentiate Graves' disease from Hashimoto's thyroiditis. In limited cases, it might be helpful. The most important and helpful tool is radioactive thyroid scanning, and as you can see here, this is how it looks, the normal thyroid scan, and this is the Graves' disease. It shows you the diffuse uptake, and toxic nodular goiter where you get hot and cold nodules, and in toxic adenoma you will get a single uptake nodule, and in thyroiditis you will get reduced uptake. Sorry for being fast, but for the sake of time. So this is the algorithm to summarize. If you suspect hyperthyroidism, check TSH. If all normal, then reconsider the diagnosis. If TSH is low, then you need to do FT4 and FT3. If both are elevated, then you can make the diagnosis of overt hyperthyroidism. If only FT3 is high, then you suspect T3 toxicosis, and if both are normal, then you should suspect subclinical hyperthyroidism. So you have to repeat the test again to confirm that this is persistent, and then you can grade. Grade 1, TSH between 0.1 and 0.4, and grade 2, TSH below 0.1. This is important because we'll decide treatment based on this. And then you have to find the cause. If the patient doesn't have classic signs and symptoms, antibody or radioactive iodine treatment. If antibodies is positive, then this is Graves'. If you need to do the radioactive iodine and you have the diffuse increased uptake, then this is Graves' disease, and again toxic nodular goiter with a localized diffusion of tracers. And if you have reduced uptake, then the differential diagnosis here is either thyroiditis or exogenous thyroid hormone. So here, you may, if you don't have facilities, you may use the thyroglobulin to differentiate between the two, as I mentioned earlier. If you have a TSH high with FT4 and FT3 high, then you should always keep in consideration the pituitary adenoma. Treatment, quickly. Treatment, the core of treatment, I think you're all familiar with, is medical, surgical, and radioactive iodine treatment. Just quickly, to control the symptom, beta blocker is a drug of choice. However, if patient cannot tolerate or they have contraindication, you may use the calcium channel blockers. Methimazole and BTU are the standard treatment. Methimazole is used more commonly in non-pregnant women. And how do you treat? You start with peak dose and taper the dose to maintenance dose. You should follow the patient in the first 6 to 8 weeks with monitoring thyroid function test. The moment FT4 normalizes, you should reduce the dose and follow the patient on treatment up to 18 months. And then there is a chance of recurrence in up to 40% of the patients in 1 year. And as we know that Graves' disease has better prognosis, multinodular goiter and toxic adenoma, they have higher chance of recurrence. So those patients may require additional treatment than medical, like radioactive iodine or surgery. How can we predict who will respond or not? That will depend on the severity of the symptoms, the requirement, dose, and also the major elevation of the hormones. Always keep in mind the side effect of the antithyroidal drug, especially agranulocytosis and cholestatic jaundice. It's lucky that they are rare complications, but they are sometimes can be dangerous. There is no clear indication for radioactive iodine. However, if you have a patient who relapses or have persistent disease, then this should be a modality of treatment, and conception should be prevented for at least 6 months after radioactive iodine, and breastfeeding and pregnancy is a contraindication. There is no major side effect other than local tenderness and pain. Surgical treatment with total or hemithyroidectomy is preferred for larger goiter with obstructive symptom in children, in those with severe ophthalmopathy, and also when you need immediate normalization of the thyroid function test. And in pregnant lady, keep in mind the preparation before OR to avoid crisis like thyroid storm. Advantage of surgery is the rapid control of hyperthyroidism. Disadvantage is the risk of anesthesia and the surgery with vocal cord problems and hypothyroidism. Subacute thyroiditis is treated with symptomatically with non-steroidal anti-inflammatory drugs. Sometimes glucocorticoid is required. You should follow the patient with thyroid function test. Some of them, they may require thyroxine for hypothyroidism. So this summarizes the management. If you have a patient with classic signs and symptoms of Graves' disease, you don't need to do further test or evaluation. You should treat with antithyroidal drug unless the patient prefers other modality of treatment, or the patient does not tolerate the medication, then you should use other modalities like radioactive iodine or surgery. Surgery, as we said, for big obstructive. Radioactive iodine maybe for smaller goiter, should avoid in people with active Graves' ophthalmopathy. And if the disease is persistent or recurrent, disease, then you may continue the antithyroid drug if the patient prefers that, or you should go for definitive treatment like radioactive iodine or surgery. If the patient relapses again, we said we just do for definitive treatment. If there is no signs of Graves' disease, then this is a problem, because you have to define the underlying cause for this hyperthyroidism, and then here you need to do the thyroid scan. Maybe antibodies is helpful, and if it is Graves' disease, you treat the same way. But if it is nodular goiter, toxic adenoma, then you should go for radioactive iodine or surgery, and if it is thyroiditis, then you treat symptomatically and follow the patient with TFT. So novel treatment, we don't have much in the treatment of hyperthyroidism, but monoclonal antibody is still being investigated as a treatment. Treatment of subclinical hyperthyroidism, this is really the challenging, whether to treat or not to treat. I'll just start quickly with this patient, Muna. She have non-specific complaint, paroxysmal atrial fibrillation, no family history of thyroid disease. She doesn't have goiter, and her pulse rate is 90, and her BMI is 23, TSH is 0.1, FT4 and FT3 normal. So how many of you will treat this patient with methimazole? Raise your hand. How many of you will just observe her and read TFT in 12 months? Yeah, okay, so I agree with you that we should observe this lady, natural history. 50% of patients with subclinical hyperthyroidism, they go to normal within 1 year, 5 years. However, up to 15% per year may go to hyperthyroidism, and that will depend on the underlying cause. Nodular goiter is unlikely to resolve, so they may have persistent, and also the lower the TSH, also the higher the risk of converting to hyperthyroidism. So how would we treat? Which one to treat? Again, you can depend on the age and the TSH level. So if the TSH is below 0.1 and the age is above 65, then you should definitely treat those people. If the age is above 65 and TSH again between 0.1 and 0.4, you may treat those who are symptomatic, have osteoporosis, postmenopausal, and those who have cardiovascular disease. Again, if you have an age below 65 and TSH below 0.1, you may probably treat. And if young patients with grade 1 or TSH between 0.1 to 0.4, then you should observe and not treat those patients, especially if they are asymptomatic. And the guidelines agree with what we have said, treating symptomatic people with osteoporosis and elderly population. There is different treatment. Treatment again, medical. If you have mild Graves' disease, radioactive iodine, especially for multinodular goiter and toxic adenoma, and surgery if you have obstructive goiter or you have suspicion of malignancy. As we mentioned, toxic multinodular goiter, toxic adenoma, they have persistent course and they will require other treatment other than medical treatment. Quickly, Graves' ophthalmopathy takes place in up to 50% of the cases. And how would you treat? If you have mild disease, whether it's active or not active, you should wait and see for the ophthalmopathy. But if you decide for radioactive treatment and the disease is active, it is recommended to give them steroid. And if the disease is moderate to severe and active, then high dose steroid is required. If the disease is inactive, then rehabilitation surgery is required. But if you have a side-threatening disease, then antithyroidal drug to treat the hyperthyroidism, you should avoid the radioactive iodine here. And if you do, you have to give IV steroid and you consider decompression, and in addition to supportive treatment. In pregnancy, the prevalence is up to 0.2%. We know that it has a side effect with both the fetus and the mother. And in regard to treatment, both PTU and methimazole crosses the placenta and with some side effect. However, recommendation is to limit BTU for the first trimester, and in the second trimester, change those patients to methimazole and follow and monitor their thyroid function test. Subclinical hyperthyroidism in pregnancy is really difficult to diagnose because we know that in the first trimester you will get reduction of the TSH, which looks like subclinical hyperthyroidism, and this is physiological. So you should be careful, and also people with hyperemesis gravidarum, they may have similar picture. So diagnosing subclinical hyperthyroidism in pregnancy is really difficult, and it is recommended not to treat and rather to keep the patient in the subclinical hyperthyroidism. This is different than subclinical hypothyroidism. Subclinical hypothyroidism you have to treat. Lastly, the thyroid stone is a life-threatening condition. It's an emergency with high mortality. When patients need to be admitted to the ICU, treat them with supportive treatment and intravenous hydrations, sedations, and IV methimazole or BTU. Convert those antithyroidal drugs to oral when they can tolerate, and IV hydrocortisone may be required. And in some severe cases, they may require treatment with plasma exchange or plasmapheresis or peritoneal dialysis or even emergency surgery. So in conclusion, ladies and gentlemen, thyrotoxicosis is a common condition. Subclinical disease is even more common. TSH is best screening, and free T4 should be used to confirm the condition. Radioactive iodine and scan is the preferred imaging tool. Ultrasound should not routinely be used unless you have indication for that. Treatment with antithyroidal drug, methimazole or radioactive iodine usually is preferred over surgery because of the side effect of surgery. And treating subclinical hyperthyroidism, if you have a TSH below 0.1, elderly populations, evidence of cardiovascular disease or osteoporosis. And we know that toxic nodular goiter and toxic adenoma, they have persistent disease and is likely to recur, so they need more definitive treatment as compared to Graves' disease. And with that, I would like to thank you, and if you have any questions.